Welcome to the National Association of Community Health Centers Million Hearts LinkedIn Live series entitled Heart to Heart. Today's topic will be empowering patients for their cholesterol, and we'll talk about blood pressure control in our next session. I am Dr. Theresa Jacobs. I am the medical officer for the Georgia Primary Care Association, and I'm your host today. For the first of a two-part LinkedIn Live series, it was actually designed to help clinicians empower patients to take key steps in managing their cholesterol and high blood pressure, and therefore reduce heart disease as well as stroke. While May, and I'm sure many of you remember that May was Stroke Awareness Month, and there was a lot of good news that took place there. A lot of good attention was given to heart disease in the month of May. But cardiovascular disease prevention is a topic that we really need to discuss year round because, believe it or not, it is still the number one cause of death in these United States. Every year, more than 1.5 million Americans suffer from a heart attack or even a stroke, which is why I am so delighted today to join my colleague here, Dr. Larry Sperling. He is the executive director of CDC's Million Hearts program and a leading expert in cholesterol management. He's here to he talks to clinicians on ways that we can really help our patients get their cholesterols under control, especially when it comes to statins, right? I also want to welcome all of you that are joining us today virtually. We welcome you to make your comments, ask questions in the chat, and we'll answer as many of those as we can during our Q&A portion. Now, I know that cholesterol control is an ongoing challenge for many of my patients, and I'm sure with your patients. And we talk to them about their general health. We do the nutrition, the exercise, and we also tell them about statin therapies. And we have to figure out a way to help them be successful in that. And I know you know this, that is easier said than done. And so, Dr. Sperling, we have a lot to discuss today. So let's get started.
Yeah, let's get started. First of all, Dr. Jacobs, want to thank you for your leadership in the Georgia Primary Care Association. Thank NAC for the invitation to have this important conversation with you today. It truly is a heart-to-heart conversation. And if we look at the platform of the Million Hearts Initiative, which is building healthy communities, optimizing care, and focusing on a core of health equity, our conversation today really hits the lane of what we say are the ABCs of Million Hearts, and the C is all about cholesterol management.
All right, that's exactly right. And so let's get to it. There's some misinformation and there are myths about statins, and I'm sure that we all have heard it from our patients. So let's start off by asking, what are some of the key facts about statins that you share with your patients?
So this is a really important introductory question, and we'll start the conversation here. One of the things I've learned is when you lead with misinformation and myths, although these are out there, when you search statins, you will find a lot of misinformation. What's most important is to lead with the truths. So what I'd like to do is share the statin truths. And simply, statins are well studied. They're actually among the most well studied of any type of pharmacotherapy we use. They're well tolerated. And then the most important point is statins work. They save lives. So although we reference statins as medications that are cholesterol lowering medications, and that is a statin truth, when you have a conversation with a patient about the potential benefits, risks, and side effects of statins, which we surely should do, it's important to emphasize the statins save lives. And you pointed out that last month was Stroke Awareness Month. Statins save lives. They prevent heart attacks, strokes, cardiovascular events, and need for revascularization. When we also talk about statins, they are all about the Million Hearts Initiative. It's the implementation of proven and effective therapies. And those proven and effective therapies, which are readily available for each and every one of our patients at risk, can help towards the possibility of preventing 1 million heart attacks, strokes, and cardiovascular events in our nation by 2027.
All right. Thank you so much for that answer. And we're going down to the second question that I'm sure is on the right at the edge of everyone's mind. And that is, conversations about statins can be rather overwhelming when we talk to our patients. And what advice do you have for clinicians, for us, as far as the benefits of statins, and that will give them the confidence and the knowledge to empower their patients to take the medications?
Yeah, both for those who are listening that are members of the lay public and for the clinicians, those who are charged with running hospitals and health systems. The conversation is all about safety and trust. Mm-hmm. So it's about relationships, it's about confidence, and it's about listening. And these conversations don't have to occur in a 15-minute time frame. I'm a clinician as well, and I fully appreciate the challenges of clinical medicine today, but I am grateful for the opportunity to partner with my patients. So we talk about the concept of shared decision-making. I like the concept of partnered care. And when I talk to a patient, I say, this is a team effort, you and me. And because you're the patient, you always get more votes than me. So we want to listen to their questions, listen to their concerns, and this ongoing thread of a conversation we call the clinician-patient risk discussion. In the chat should be a link to a paper we published in the Journal of the American College of Cardiology in 2015. And this is a core element of our cholesterol guidelines. So we should begin with this conversation. I do appreciate that many people have questions and concerns about beginning a cholesterol medication like a statin, especially when they're feeling well. Mm-hmm. If they're identified to have high cholesterol, or just as important, maybe an average cholesterol level, but they're a high-risk individual, somebody who has diabetes and they're middle-aged, somebody who has been identified to have an LDL or bad cholesterol greater than 190 milligrams per deciliter, which should make us raise the question that they have a genetic cholesterol problem, and somebody who is at a high potential risk in the next 10 years for a cardiovascular event. Now, in people living with established heart and blood vessel disease, we know this is a clear high-risk population, and we should have that conversation based upon the likelihood of a second event, and so we call that secondary prevention. The population who have risk factors, that's a primary prevention population. So we begin this conversation, we talk about risk, we talk about questions, we talk about concerns, and often what I do is, let's just say, and you want to be very aware of nonverbal cues. So when I teach our students, our interns, residents, and fellows, when we start having this conversation, if you see the patient take a back step on the chair, or their body language becomes a little bit defensive, I might introduce the idea of a statin by saying, these are medications that save lives. We don't have to make this decision right this second, but if I were to prescribe a statin for you, it would be this, at this dose. So why don't you think about it, do a little research on your own. And between now and your next visit, if you'd like to get started with a medication, just send me a message. And I can't tell you how many times I get a message back saying, Dr. Sperling, I appreciate your patience with me and understanding. I did do some research and I've thought it through, and I'd like to get started before our next visit together.
Oh, I think that is great. I have a number of patients and family members that they'll start taking that statin, and the first little cramp or something that they get, because that's what they heard, they'll stop taking it, and they'll say things like, "My cholesterol is fine," but I have a relative. My mom died at 49 of a massive heart attack, and so you see me drinking my water. I'm on a statin. I'm on that baby aspirin as well. What? Because it's just a challenge though to talk to these patients and to get them to really stick to it, and like I said, that first little cramp that they get, they stop the medication. And I'm just wondering, when do you start juggling statins, the dosages and all of that? When do you start doing all of that?
Yeah, first of all, very sorry to hear about your mom. And there are many in our country that are living with stories like your mom. One of my motivating factors to become a preventive cardiologist was my grandfather had a heart attack in his 40s and died young, and there's heart disease in my family as well. So in most families in our country, we find stories like this, the consequences of heart disease, stroke, and cardiovascular events. Well, there are questions about statins or any medication. People don't necessarily want to take a medicine, especially if they feel good. And so as part of that conversation, if there are concerns or questions, for instance, most people have aches and pains. And there are what we call statin-associated side effects, the most common being statin-associated muscle symptoms, or SAMs. We think these occur in clinical practice maybe about 10% of the time, but the statin-associated muscle symptoms are not, ow, my shoulder hurts. They're typically bilateral, so both sides of the body, the large muscles in the arms and the legs. And the way I describe these side effects or symptoms are, you might feel like you have the flu, but you don't. And so if you do notice these type of symptoms, to let our team know, and we can always reduce the dose of the medication or think about another medication or another dosing regimen. It's often finding the right statin for the right patient, which we know we can almost always do. But often patients are deemed, quote, statin intolerant if their shoulder hurts. And their shoulder hurts probably because they were playing too much tennis this past weekend. And we actually have tried to take statin intolerance away from the lexicon. If you read the 2018 cholesterol guidelines, I was on a member of the writing committee. If you read all 210 pages, however many pages are there, that term is never used because most people will be tolerant of a statin. It's finding the right statin for the right patient. A question I've learned to ask is, and also just to have a signal, if you have somebody who's been taking a statin and all of a sudden you see their cholesterol levels go up, one of the reflexes for a clinician is, oh, let's just increase the dose. Well, why don't we, I always say, when in doubt, listen to the patient. So the first question I would have is, in a non-judgmental fashion, I would ask that patient, how many times a week or month do you miss taking your statin? Because here, often there are many issues behind what we call non-compliance and non-adherence. And so we should never blame the patient. We should listen to the patient. And what's behind it might be either just a busy life or cost issues, or they're taking many medications and they haven't quite organized the game plan. So just like with any other medication, you want to pair taking your statin with some other daily event, whether it's brushing your teeth in the morning or getting ready for bed at night, for instance, or with dinner. Some of the earlier statins have a short half-life, and so it's best to take them in the evening. They're most effective. But the newer statins with longer half-lives, you can take them any time of the day as long as you take them each day. The flip side of, because this is all about partnered care, it's about a team, the flip side of what we call non-adherence is therapeutic or clinical inertia. And this is on us. Yeah. We should take every opportunity we have with a patient, whether it be in the office or now through electronic messaging or telehealth or telemedicine, to ask and listen. We should take every opportunity to remind patients that statins save lives. And with these opportunities, it's also a chance to listen to concerns and reinforce, as you said when you let off, Dr. Jacobs, that although statins are foundational in terms of cholesterol management, really the base foundation for cardiovascular disease prevention is a focus on a healthy and lifestyle approach for an individual, a family, and a community. So healthy dietary patterns, regular moderate physical activity, not smoking, or if you are smoking, to focus on tobacco cessation. And comprehensively, of course, we want to address all cardiovascular risk factors. So as well as cholesterol, we want to focus on blood pressure control and either diabetes prevention or diabetes management.
All right, so that's real good. I am, like I said, I take that statin every day. What do you say to those patients that say things like, well, my cholesterol is fine, and so, or once I get it down, I can just come off the medicine, because that's what we hear frequently. I can just come off, right?
So yeah, I think a lot of this is that conversation we have from the beginning and the thread of the conversation, because people, especially if they're not feeling badly or they have not had a prior heart attack or stroke or cardiac event, they just assume exactly what you just said. Well, I've taken this medicine for a couple of weeks or months, and hey, look at my last labs. My cholesterol's a lot better, so I'm good to go. And these medications, of course, don't work if you don't take them, and they certainly don't work if your clinician does not prescribe them. And I get often asked, do I need to take this the rest of my life? And my answer is, there's no decision that we're signing you up for the rest of your life. This is a team approach. Together, as you get older, if the equation changes or your preferences or thoughts were to change, we can always think about reducing the dose. We could potentially stop this medication. However, we come back to what I said during your first question. Yeah. This is more than a cholesterol lowering medication. And so as you move on through your life, if one of your important goals is to not need to see the cardiologist in the hospital, the emergency room, or the intensive care unit, then this one pill a day, or sometimes you could be taking a statin a little less frequently, will significantly reduce the likelihood of a major cardiac event.
Oh, all right. That's great. I enjoyed that. Now, since we have a cardiologist here and we're talking about cholesterol, so for the clinicians that are online, a lot of times they when they draw that lipid profile, there's some issue as to whether or not it should be fasting, and then there's some concern about, well, how often should we draw those labs? So I just want to throw that in there today, just so you can address that for the clinicians.
Yeah, our guidelines say that you do not necessarily need to be fasting.
Mhm.
So if you have a patient who's in the office, even if they haven't fasted, it would be appropriate to measure a lipid profile. The fasting, what it does is reduces the circulating triglycerides or fat in the blood. And the equation we have, or the equations we use to calculate some of the components of the cholesterol profile, can be dependent upon those circulating fats. So you can do a non-fasting. A simple way, both for clinicians and the lay public, I always say the LDL, it's the lousy cholesterol you want lower. The
Okay.
HDL, that's the healthy cholesterol you'd like to have higher. Your question about how often should we measure for the pediatric age group, our guidelines recommend that all children have a cholesterol profile in and around the age of 10. Earlier, if they have a family history of high cholesterol or family history of early heart disease, all adult Americans should have a cholesterol profile at least once every 5 years over the age of 20. Now, when you've started a statin, we usually do some follow-up labs in about 2 to 3 months. That should be significant to see the impact of the statin. We used to be more concerned about measuring liver enzymes and other things that
Yeah.
uh, were in the list of statin related concerns. And unless somebody has a high risk for liver disease or active liver disease, we don't even recommend measuring liver enzymes
Wow.
anymore routinely. And if you're on a stable dose of a statin and you haven't added other medications to your medication list, at that point, you could measure a cholesterol profile once a year.
All right. Thank you. Thank you so much. We do have some resources that we're going to be sharing. They're going to be placed in the chat so that you all will have access to those because there are quite a few of them. Just look into the chat, click on those links, and it will bring up those resources. Well, Dr. Sperling, I think we've come to the end of this LinkedIn Live discussion. I think I picked your brain enough here on today. So I want to say thank you. What there's a question in the chat. Oh,
Yeah, we're glad for a couple of minutes. If there are questions or comments in the chat, we'll try to field those. It looks like the first two we've already addressed in our
yeah.
conversation. So don't lead with the misinformation or myths, but lead with the statin truths
Mm-hmm.
and emphasize that the majority of people will be able to tolerate a statin at an appropriate dose. So finding the right statin for the right patient. In the chat will definitely be some resources from NAC and Million Hearts and a paper that I mentioned earlier on with the first author being Seth Martin. And it's all about that clinician-patient risk discussion. So it's a valuable paper to read to dig in a little bit further. And the frequency of labs, I believe we've touched on already.
Yeah. All right. So I believe we've come to the end of this LinkedIn Live. And I really want to thank you for helping us dive into some really, critical questions when it comes to statins. And I love, your shared experience and your expertise in managing patients that have high cholesterol or have those risk factors. I hope everyone today who joined us is walking away with a few new tips. I know I have. I've gotten a few new tips here and strategies for empowering your patients who would benefit from a statin. I'm going to encourage you to visit the CDC Million Hearts and the NAC Million Hearts websites for more clinician as well as patient resources. And like we said, we're going to post all of those in the chat. Let's see. I also want you to know that the part two of this will be July the 20th at 12:30, and that topic is going to be a discussion on best practices for using self-monitoring blood pressure tools with our patients. I think that's going to be great. So July the 20th at 12:30, put that on your calendar. As we end, every 3 seconds in the United States, somebody's dying from cardiovascular disease. And so I'm going to encourage clinicians, get that statin, put it on. It's just another tool in a toolbox. And let's see if we can save 1 million hearts.
Thank you, Dr. Jacobs, and truly enjoyed this